Okay. Good morning, everyone. Welcome to the UKMS Spring Day here at the Cavendish Centre. Thank you, everyone joining us in the room, and also to everyone joining us online. I think we actually have equal numbers of in-person and online attendance this year, which is just great to see. So the title for our day today is Controversies and Uncertainties, and we're going to try and answer some unanswered questions in myeloma. And any of us who do myeloma day in, day out are often faced with questions that we find it difficult to answer. So please ask questions as we go along. We'll give opportunities at the end of every session to take questions from the floor. We'd also like to encourage questions from online participants to be submitted, and we'll try and get through as many of them as possible. In terms of who the UKMS are and what we do, we'd like to invite any of you that aren't UKMS members to join, and the information for joining can be found on our website. We'd also like to draw your attention to the fact that this is our 25th anniversary, and so it's a big celebratory year for us, and it's good for everyone to get involved. UKMS exists for education of doctors, nurses, pharmacists, everybody that's involved in the care of myeloma patients. We also do a lot of work in patient advocacy through NICE. We produce guidelines, and we are only as strong as our membership, so please get involved. We also would like your feedback on today, positive or negative. We're open to hear all of it, so please submit your feedback forms at the end. And also, there are groups within UKMS that we welcome participation from members. So Jonathan Siv, who unfortunately couldn't be here today, would like to make a plea for anyone to join the education group. Please contact Jonathan for that. Also, Simon Stern is chair of our guidelines group. The guidelines group in myeloma has been prolific over the last 6 to 12 months. Please check out BJ Heem for good practice papers coming through on smouldering, hopefully imaging, and lots of others coming through, and get involved. We also have the UKMS and Myeloma UK seminar series. That's a series of webinars that take place online. The next one is going to be on the 16th of April, and that's on bone disease and imaging, and that will be given by myself and Roops Chowdhury. So again, if you haven't seen that advertised, and if you have time to join, then please sign up for what will hopefully be a great online webinar. In terms of a plug for our next day, the Autumn Day is going to be on the 14th of November. There may be something else important happening on that day, but clearly the UKMS is the most important thing, so please sign up there. We're going to be celebrating our 25 years again. We'll have a great Michael Morley speaker. We're actually going to have, hopefully, representation from the Michael Morley Foundation. Michael Morley was a patient with myeloma many, many years ago who unfortunately passed away, and his family have supported the charity ever since, and we're very grateful to them. Thank you to all our speakers. Thank you to our sponsors. Please check out the sponsor stalls at the break and during the lunch break, and interact and get involved with everyone that's there from our pharma partners. Thank you to Andy and to Sally Moore for putting together the program today. It looks like a great program, lots of great speakers. Andy Charlton from Newcastle will be chairing with me this morning and during this afternoon. We're very sorry that Sally couldn't join us, and we send our love to her even though she's not in the room. And thank you, as always, to Wendy, without whom the UKMS would fall apart, and to Derry and Alex from Collaborative Conferences for also all the very smooth arrangements. Okay, so after all the introductions, we'll get started. If you look at your programme, it says UK Practice Update Jonathan Siv. Now, Jonathan Siv today has been represented by 3 lovely ladies, so you'll hear on the medic side, on the nursing side, and on the pharmacy side about what changes are happening in the UK myeloma practice world. So I'd first like to invite Catherine Locher, who is the new chair of the UKMS Pharmacy Group, to come to the stage. Thank you, Catherine.
Good morning, everyone. So with the approval of DRD late last year, that has created capacity problems in a system where we already had capacity issues with delivering SACT. So one of the models that can help with delivery of SACT is our outreach services. And I'm going to give you a very brief overview of my experience of the outreach services at Nottingham and Leicester, which are both based on the Birmingham model. So both in Nottingham and Leicester, trust-employed nurses will administer SACT in patients' home. The model has significant advantages over other externally outsourced providers. The Nottingham model was funded for 2 years from Kay Kendall Leukemia Foundation and the NUH Charities Fund, and Leicester have managed to fund a pilot internally with some increased money from increased activity. The Nottingham service does a lot more than subcut monoclonal antibodies, and they delivered 4,600 visits in their 7th year. The graph on the left shows you that they are, for 22-23, they delivered over 50% of their daratumumab doses in patients' homes. The Leicester model is still in its infancy, but since the end of September, they've already delivered 135 doses in patients' homes. I just want to thank my colleagues at Nottingham and Leicester for providing the data, and I've provided their contacts there if people wanted to speak to them about how the model's been set up. Just finally on outreach, the governance framework which they operate in is incredibly important, and not only do you obviously need the policies, procedures to support it, but think about existing trust policies and how you adapt those to a community setting. Important to risk assess a number of areas, so lone working, single nurse checking, transportation, and obviously documentation is important. So moving now to DOACs, at the UK Pharmacy Education Day in November, Peter Baker presented the UKMS survey for DOACs for the prevention of imide-associated thrombosis, and he's kindly let me use his slides today. So on the left, you will see that 60% of respondents, and it was a good response to the survey, over 50, I think it was 52 responders. 60% were using a validated thrombosis risk assessment tool, but there was some variation. On the top right there, that picture's a little busy, but it shows that 96% of responders were likely to use a DOAC, and not unexpectedly, warfarin is unlikely to be used, and the DOAC of choice was apixaban. So there is a growing body of evidence for the use of DOACs for the prevention of imide-associated thrombosis. We do need more prospective randomised control data, but the survey demonstrates that DOACs are already commonly used. And for us and Peter Baker have drafted a position statement, and that is currently being reviewed, and hopefully we will have that by the end of the year. Thank you.
Okay, so thank you, Catherine, and thank you to Jonathan for putting these slides together. So in terms of the UK clinical update, this is the current iteration of the NICE treatment algorithm for myeloma. One thing I would say is it feels like it changes on a very regular basis, and it also looks very busy. So we've had significant approvals in the frontline non-transplant eligible setting, as Catherine just mentioned, with the approval of Dara-Lendex. We'll come on to it in a bit, that we are looking at several appraisals in the relapse setting that will hopefully be added to this algorithm in the not too distant future. The one thing to say about it being so busy is obviously there are many drugs that appear several times, and as we all know, using them beyond refractory isn't always beneficial. So there is a lot of work going on in the background to try and improve access and then lack of access to certain treatments that we all know are missing from this algorithm. But nevertheless, recent NHS England approvals include DRD for newly diagnosed non-transplant eligible patients. This is likely to be the first-line choice for most TNE patients. Certainly in my practice, that's what we're doing, apart from the perhaps very elderly, very frail patients who would struggle to come to the day unit for weekly daratumumab, who may opt for an oral option. This has also been approved by the SMC in Scotland. They actually approved it first, and it's also available in Wales and Northern Ireland. In terms of notable progress, selinexor has been working its way through NICE and NHS England in combination with Velcade and dexamethasone for treatment of patients at second line who have progressed on DRD. So these patients would be naive to a PI, and there's been a lot of work going on around behind the scenes in order to get SVD positioned at that point. The advantage to those patients is that they wouldn't be eligible for DVD because they're DARA refractory. Also, other options at second line, KRD wouldn't be available as they're refractory to lenalidomide, and KD in an older population could provide challenges, although it can sometimes be delivered with modifications. But SVC at second line hopefully will be there and confirmed. And then the other big one for the amyloidosis community is that finally daratumumab in combination with VCD has been approved for newly diagnosed AL amyloid patients. We're actually still waiting for the final publication of that, as expected on and around the 27th of March. This is an appraisal that's been to NICE, it's been turned down. There was appeal with a lot of support from the amyloid community, and it really will be a game changer for them off the back of the Andromeda data. So thank you to everyone that's been involved with that. In terms of applications that are in process, there are some drugs that have previously been on the Cancer Drugs Fund that come to the end of their CDF life and need to be approved or not approved. One example of that is isatuximab in combination with pomalidomide and dexamethasone at fourth line. This is still in the consultation process, and we can't yet say for sure whether or not ISA-PD will remain at fourth line, but again, there is a lot of work going on around that. Belantamab at fifth line has also been looked at. That's currently on hold because as yet belantamab doesn't have an MHRA license, although that is in progress. Then we come on to the bispecifics. So there's two BCMA-directed bispecific antibodies that are going to NICE this spring. Elranatamab was there last week on the 14th of March, and myself and Gordon Cook did that appraisal. So that's for triple refractory patients, fourth line plus. And then hot on the heels, there is teclistamab, which I think is next week or next month, very soon. Similar BCMA-directed subcutaneous bispecific antibody. And, you know, we really hope that one or both of these drugs will get through because there's a huge gap. That algorithm that I showed you, it looks very busy, but there is nothing BCMA-directed on there. So we just have to keep working until we get one of them through. And then finally, selinexor with dexamethasone only at fifth line. There are commercial negotiations going on to see if that can be made available. Again, selinexor is a drug that has a different mode of action. It's oral, so can potentially benefit some patients in the relapsed and refractory setting. Also, through UKMS, Martin Kaiser heads up a really important piece of work around pathway optimization. And basically allowing the clinical community to get involved in negotiations around making treatments available that we know are effective and often will have a license even though they've not been through the NICE approval process. So an example of that might be PVD, which has not really been used much in the UK, and there may be restructuring that can be facilitated to allow that to happen. That none of those things have actually got over the line yet, but we are working hard behind the scenes to see what we can do to try and make the pathway fit better and work better for patients. Another example, which I'm sure all of you will have thought about, is, well, if we can use DARA VTD, why can't we use DARA VRD, especially now R is cheaper than T? That, again, there's work going on. It is actually a cost saving in comparison to DARA VTD, but as you might imagine, it's still not a simple process. But again, watch this space, keep an eye on our website and other websites for further information about that. Okay, so that's all from my clinical update. I'm just going to hand over to Jackie to give some perspectives from a nursing point of view. Thank you.
Good morning, everyone. You've heard a bit about all the new treatment options that are available, and the challenge is how do we deliver these practically in the clinic. In Belfast, we lack an outreach service. We don't have the ability to outsource any of our treatments, and we don't have treatment hubs. But what we do have is a robust routine non-medical prescribing group, and that has led to us developing a nurse-led myeloma treatment clinic. So to meet service needs, it's evolving. It has been in situ really and working for about approximately 14 years. In the early days, it was Velcade-based therapies. We now have isatuximabs, carfilzomibs, daratumumab-based therapies, and all of those are treated through a nurse-led treatment clinic. Everyone's gone through the capacity issues, and Catherine has alluded to that already. That's only going to become a bigger problem the more treatments we have, and we do want to get treatments in a timely way and monitor our patients and deliver safe and effective care. A bit more about the myeloma treatment clinic, what it actually looks like. It's run twice weekly at the moment. We use holistic needs tools. Patients do have access to physio and OT services. Given that myeloma is primarily a disease of elderly folks, this is essential, helps with prehab patients undergoing transplant, and also exercise and OT services to keep them independent and safe at home. And they feel that by visiting the hospital and coming to the day unit that for treatment, that their day is actually very usefully supported. I usually also take the opportunity to signpost and refer these patients to other supportive services to keep them independent and safe at home. That could be financial services, it could be psychological support, and patients do report that they find that very useful. There's also ongoing education about their disease, their medication, scheduling of treatment, which is essential for keeping compliance and obviously improving patient outcomes. There are close links with the consultant team and support from them, which I think is essential in order to keep patients safe and manage any toxicities that may arise during the course of their treatment. It's been well evaluated by patients. We do patient satisfaction surveys, and patients feel that key thing for them is that they do not want to spend time on our day units, or if they do have to, it's the bare minimum. So we're achieving that, and they feel that their time is very usefully used in that any other additional needs that they have are met. It has streamlined our service. Patients are cohorted to attend clinic, and they attend the treatment clinic, and that's separate to their consultant clinic visit. And we do try to ensure that both happen on the same day, make best use of patient time, and use our resources effectively. Moving on, Myeloma Treatment Scheduler is a new tool that is available as an app or online for patients. There's increasing complexity of polypharmacy in this patient group. Patients are on multi-drug regimes, and we do adopt a lifelong treatment approach. So it is really important that patients are well informed, that they're well educated, and that they understand their treatment, the schedule, the supportive meds, and that's key for compliance. Producing treatment schedules is really common practice in every clinic. Nurses and pharmacists do it in every clinic. It's very time consuming, and it has to be adapted to each individual patient. And that again adds to the time that we spend developing these. The Haematology Society of Australia and New Zealand, Tracy King et al., have developed a tool which we have adopted in the UK in a pilot scheme. It includes chemotherapy regime, the supportive meds that these patients, and adapted to their particular circumstances, the bloods and phlebotomy that's required for their regime, and their clinic appointments are all captured on the one document, which is really useful. It can be adapted for every individual patient. There are a number of myeloma treatment regimes and SAC schedules that are available on it, and we are looking to see that we can adapt that to meet the needs of the UK patients. The lead on this project at the moment is one of our pharmacists, Fran MacArthur, and Catherine has her contact details should you want to find out more information about that. Thank you.
Thank you to all our first few speakers there. I think in the interest of time, we've got one question online. We might be able to come back to it, but in the interest of time, I'm going to move straight into the UK trials practice changes, and perhaps we'll be able to come back to some questions at the end. So Rakesh Popat is going to come and speak to us. He's a consultant haematologist at University College Hospital, associate professor at UCL, and a special interest in multiple myeloma, and he leads the myeloma clinical trials program and is cancer program lead for the NAHR UCL Hospitals CRF. And amongst many other achievements, he's the chair of the UKMRA, member of the exec board at UKMS, and a member of the International Myeloma Working Group, and he's going to update us on the status of the UK myeloma trials field. Thanks, Rakesh.
Wonderful. Thank you for the kind invitation, and very good morning to you all. I've got the task of, in 10 minutes, telling you all about the myeloma clinical trials program, so it will be fast and furious. And I'll also tell you all the answers for today's controversies, so you can go for a coffee afterwards and sky that. But I'm getting dirty looks from my chairs down across, so I'll move fast through my disclosures. So these are the current questions in myeloma that the research collaborative group is dealing with. And I'm going to take all these in turn. The first is, can we use MRD to guide treatment choice and treatment duration? So we're looking at this with the RADAR trial. This is myeloma 15 and is for transplant-eligible patients. And you can see that patients are stratified according to their cytogenetic risk. And then what's very important here is that there is an MRD-driven pathway in the standard risk patients. So patients who are MRD negative following a transplant get a CD38 maintenance pathway, and importantly, if they maintain the MRD negativity, they are randomized to either stopping maintenance or continuing long term. Now, if these standard risk patients continue to be MRD positive, then that is potentially a more of a higher risk situation. Then they are randomized to have continuous treatments, and these cassettes will tell us what they should do. Now, clearly, high-risk patients should not stop treatment with the data that we have available, and they will proceed through this pathway with a more intensive field. So the question is about the high-risk pathways, that we know that this is a very difficult to treat group of patients, and how can we do better with that? Well, we've already had some excellent data, which was from the MUC9B clinical trial that was led by Martin Kaiser and Matthew Jenner. And many of you may have seen this data, but I just want to briefly highlight the excellent results. So we had a 5-drug induction regimen, a transplant which was bridged with a bit of bortezomib. But I think one of the most important features is this 18-month consolidation block with Dara, Velcade, Revlimid, and a bit of dexamethasone initially. And that sets it apart from many other clinical trials that we've been seeing, and of course with the doublet maintenance with daratumumab and lenalidomide until disease progression. Remembering that this was an ultra-high-risk population, so patients who had 2 high-risk cytogenetic features or plasma cell leukemia, or high-risk as defined by gene expression profiling. And the results were excellent and showed a significant improvement in progression-free survival compared to historical controls from myeloma 11. So the question is, how can we build on this excellent work that has been already been performed? So this is the proposed high-risk arm from RADAR. We're currently just finalizing some funding. But what you can see is that these patients will also receive a 5-drug induction, very similar to Optimum, but they will then receive intensification pre-transplant with a BCMA-directed bispecific antibody. They'll flow through the transplant route and then have an 18-month post-transplant consolidation, also incorporating a BCMA bispecific. And we have an interesting alternating schedule of a bispecific and lenalidomide with a CD38 and lenalidomide in order to try and reduce the toxicity profile and reduce T-cell exhaustion, which is a problem with continuous bispecifics. And then you have the doublet maintenance until disease progression. So we're hoping to roll that out later on this year if all the funding comes through. So watch out for that, and we'll be keen to have all sites on board with this pathway. But of course, it's not just high-risk cytogenetics which is a problem. There is a functional high-risk population, and Kerry Bygrave published this data from myeloma 11, which showed that patients who relapse very early following a stem cell transplant clearly have an inferior both progression-free survival and an overall survival. So again, this represents an unmet need, and that we need to develop novel pathways for this. So this is the IMMERSE trial, which we are currently setting up and hope to open either at the end of this year or earlier next year, and is for patients who relapse within 24 months of a stem cell transplant, who will go on and receive a BCMA-directed bispecific antibody in combination with pomalidomide and dexamethasone for 24 months, and having a 12-month maintenance with pomalidomide with a primary endpoint of progression-free survival. We're actively looking for sites, and you'll be having feasibilities come through, so please do let Leeds CTRU, who are coordinating this study, know if you're interested and willing to participate. So the next question is, how do we manage older patients with myeloma? And Charlotte Paulin published this data from myeloma 11, which clearly showed that for older patients that the performance status becomes more relevant in terms of overall survival compared to cytogenetic risk in terms of how they're going to survive. Now, what we know is that performance status is quite a blunt tool, and that frailty assessments are far better. And so you may be familiar with the fitness trial, which has been running for some time. It's being led by Gordon and Graham Jackson. And this is randomizing patients from a reactive dosing strategy compared to a proactive frailty-adjusted strategy, which you can see here. And this trial has almost completely fully recruited, so there's a final push for the last remaining patients. Please do enroll these patients so we can have a readout for this very important study. So the question is, what's coming next? And Gordon has traded in Gordon Jackson for Charlotte Paulin here, and they're going to be, and I hope that is an upgrade, Graham's not here. And what you can see here is the proposed IFIT study, which is coming through hopefully next year, which is using the DRD backbone, and again, importantly, using an MRD-directed pathway and a frailty-adjusted pathway. So very important, bringing these two MRD and frailty-adjusted features in, and incorporating, very importantly, bispecific antibodies into this world. You'll hear loads about this study as time goes, so don't worry about the detail. I'm just giving you a flavour of what we're doing. Now, our patients are always telling us that we need to improve quality of life and reduce the treatment burden. And we've taken this on board with 2 studies which are currently running through our portfolio. The first is incorporating the BCMA-directed antibody-drug conjugate belantamab mafodotin. We know that this drug is highly active. These are the results from the DREAM7 study, which have just been published, which show belantamab, Velcade, dexamethasone having a superior progression-free survival compared to daratumumab, Velcade, and dexamethasone for relapsed patients. So we know it's an active drug. But we also know that the major toxicity, or the commonest toxicity, is that of corneal problems, as shown in this slit lamp examination, which leads to multiple visits to the ophthalmologist. So how can we reduce that treatment burden to the patients and reduce the toxicity with belantamab? So this is what we're doing with PROMISE. This is a trial which is currently enrolling. We are using a Q8 dosing of belantamab to reduce the ocular toxicity throughout all schedules. And then importantly, Arm D, which we hope to get going very soon, will be using a patient-reported outcome questionnaire, which we delivered from DREAM2, which we hope will take the place of ophthalmology visits and thereby reducing the treatment burden onto patients. So I think this is a very important study from a patient perspective, and we look forward to patients being enrolled into this trial. The second study to reduce toxicity is a study trying to reduce the burden of cytokine release syndrome. We know that with bispecific antibodies, CRS occurs in 40 to 50% of patients, and whilst it's low grade, can cause increases the number of patients being admitted to hospital and causes morbidity. What we know is that there's a drug called POLB, which can potentially reduce the risk of cytokine release syndrome by targeting P38 MAP kinase, And by targeting this enzyme, we reduce the secretion of multiple cytokines. And there is evidence that POLB001 can reduce inflammation in healthy volunteers. So this is a study which is being led by Emma Searle, and this will be looking at POLB001 as prophylaxis in the setting of a BCMA bispecific antibody in order to reduce the incidence of cytokine release syndrome and allow those patients to be treated as an outpatient. So again, a very important study to reduce the side effect for patients, which I hope you'll be able to enroll into as time goes through. Now, you may all be sitting there very stressed thinking, how am I going to run all these bispecifics in my local centre? And help is at hand. So we do have a project. Pinky Chambers, who's an academic pharmacist, is leading this with me, and we are going to be giving you all a helping hand to implement bispecifics. We have an education and implementation pathway, which will be running through Leeds CTRU and the UKMRA. We'll be holding your hand with outpatient dosing, SOPs for protocol management, CRS management, and also immunoglobulin access. We're going to be working with Myeloma UK to engage with underserved populations because we know that these guys do not access novel therapies, and working with the Mayo Clinic and Sanyas for innovation in practice. Last two slides about improving a BCMA CAR T-cell therapy. We know that this is very effective, but what can we do better to improve BCMA-targeted therapy? So this is a study led by Lydia Lee at UCL, who's building on BCMA-directed therapies and bringing in a dual CD19 BCMA CAR T-cell for relapsed refractory patients. She's treated 13 patients so far and presented the results at ASH. Very interesting study because we have two cohorts, one cohort with just BCMA patients and another cohort with BCMA and CD19 patients. You can see that the results are very good, with all patients currently responding and also patients who have a durable response. And hopefully Lydia will give us an update later on this year in this study. And then finally, should we treat with smouldering patients with multiple myeloma? This is a very controversial and thorny issue. And the way we're addressing this is by two different studies. Dean Smith is running an interventional study for high-risk smouldering multiple myeloma, where patients will receive a fixed duration of isatuximab and the new CELMoD iberdomide for 26 cycles, and then will be observed. And Kui Yong, very importantly, is running the COSMOS study, which is an observational study for patients with smouldering myeloma with an important biomarker-driven component. And this will serve as a control to our interventional arm. So it's two very important studies for smouldering multiple myeloma, which I hope that you will all take part in. And with that, I'd like to finish by acknowledging everyone who is part of the UK Myeloma Research Alliance and is listed on this slide. If you do want to get involved in our research program, do drop me a line. It'd be really great to have you all as part of this strategy. Thank you very much.
Oh, thank you, Rakesh. Such a brilliant overview in such a short amount of time. And thank you for solving all the problems of our debates as well today. We've probably got, I'm just going to ask one question here on that's been asked online, which is around outreach services. This is probably to Catherine. So the question here is, when setting up an outreach service, has there been a community aseptics unit to take advantage of VAT savings that can be made?
Very good question. So it is something that we explored at Nottingham, and the VAT rules are incredibly complex with outreach, and so there's different interpretations. So I'm aware that for antibiotics there has been some sort of VAT efficiency, but the advice we've had from our local VAT specialist is that because it's trust employed nurses, you can't then use a VAT efficient route. But I think if you ask different VAT specialists, you do get different answers.
Okay, thank you. It's really helpful. Any questions in the room before we move on? Okay, well, thank you very much to all the speakers. Thank you to Rakesh. We're going to move on to the theme for the rest of our morning now, which is what now for autologous stem cell transplant in myeloma. So the following 3 speakers are going to solve this problem for us, the following 4 speakers. And then at the end of the morning, we've got a panel discussion and a Q&A as well. So if we don't get time to get to all of the questions, we will hopefully come to them at the panel discussion at the end. So first of all, I'm going to introduce Dr. Kirsty Cuthill. She's a consultant haematologist at King's College Hospital with an interest in myeloma, Waldenstrom's, and monoclonal gammopathy of dermatological significance. Kirsty's a member of the UK Myeloma Research Alliance and the Waldenstrom's UK Clinical Advisory Group, and she contributed to the BSH guidance on diagnosis and management of myeloma. And Kirsty's going to help us know whether we should use 4-drug induction with transplant and LEN or DRD for our older transplant-eligible patients. Thanks, Kirsty.
Thank you. So for the purpose of this presentation, I'm going to classify the older transplant-eligible patient as those aged between 65 and 75 years old. And given the median age at diagnosis of multiple myeloma in the UK is 70 years, this accounts for a large proportion of our patients. Now, the management of patients who are fit under the age of 65 is very clear. 4-drug induction, transplant consolidation, and maintenance is the standard of care for these patients. But in this older cohort of patients, we have less data from clinical trial. These patients are underrepresented in clinical trials, and we spent a lot of time discussing the management of these patients in our MDTs, which brings me on to the first case. So MGG is a 71-year-old lady with a history of hyperparathyroidism, fit and active, working in her finance department at a local hospital. So she presented with worsening back pain associated with vertebral compression fractures. She had an IgG kappa paraprotein of 24 grams and a kappa lambda ratio increased at 392. ISS was 1 and she had standard risk FISH. Of course, we often don't have this information when we're making decisions in our MDTs. Bone marrow trophine shows 60 to 70% clonal plasma cell infiltrate, and imaging included PET-CT, which showed multiple lucencies with a lytic lesion in her left pubic ramus. She had an incidental avid lesion in her right hemipelvis, and she had to go on to receive a colonoscopy to investigate for possible malignancy. She had normal renal function at diagnosis, but after the colonoscopy and all the bowel preparation, her eGFR dropped to 25 mils per minute. So in this country, we're forced to make an early decision regarding whether patients are fit for transplant or whether they should go down a continuous therapy with daratumumab, lenalidomide, and dexamethasone. Of course, we also have clinical trials to consider. But this is an early decision that we make. Often this information is based on limited assessment, and it's at the get-go, so we haven't had a chance to see if patients' frailty can improve with treatment. So how do we make our decisions? Well, often we discuss the goals of treatment with our patients, and frequently these include the longest disease-free remission, whilst preserving quality of life. Other considerations include patient-specific. We consider age, frailty, comorbidities, which include cardiac and renal function, ultimately deciding early whether a patient is fit for transplant. And then, of course, there are disease-specific considerations, including ISS stage and the presence of high risk of cytogenetics. So let's have a look at the data from the 2 pivotal trials, starting with Cassiopeia, which looked at Dara-VTD induction, transplant, consolidation, and maintenance actually with daratumumab in the study. So in the first part, over 1,000 transplant-eligible patients were randomized to Dara, Velcade, thalidomide, and dexamethasone versus VTD and transplant, with the primary endpoint of stringent CR at 100 days post-transplant. And part 2 looked at the impact of maintenance. What is important is to consider that this trial only looked at patients aged 18 to 65, which is typical for transplant-eligible studies. The median age of patients was 59. These were very fit patients with an ECOG performance status of 0 to 2, good bone marrow function, good renal function of greater than 40 mils per minute, and the main exclusion was peripheral neuropathy. 15% of these patients had advanced stage disease, and 15% had high-risk FISH, as defined by the presence of 17p deletion and translocation 414. So this slide has mysteriously disappeared, but this was a consort diagram which showed the attrition of numbers of patients at various stages of the study. My point was that 14% of patients didn't make it to maintenance, and half of those didn't proceed because of treatment-emergent adverse events, despite being a highly selected young population of patients. So looking at responses, at day 100 post-transplant and at best response, you can see that patients who received Dara-VTD had really impressive deep remissions. You can see that almost 30% achieved stringent CR at day 100, increasing to 43% at best response. And within that complete remission category, patients achieving MRD accounted for 34%. And this translated into an excellent progression-free survival with a significant reduction in risk of progression or death compared to VTD. So looking at progression-free survival and death, all patient groups benefited from the addition of daratumumab to VTD. In terms of adverse events, neutropenia was significant, affecting almost 30% at grade 3-4. Infections were common in the Dara-VTD group, increased above those in the VTD, but grade 3 and 4 infections were similar across the two groups, roughly 20%. So I think it's always helpful to consider quality of life in these studies. Quality of life at baseline was actually higher than in other studies, and this improved post-induction and post-consolidation. This trial wasn't designed to look at the effect of transplant on quality of life, so we looked at other trials for that, looking at the IFM 2009 study, which randomized patients between RVD consolidation versus transplant and then maintenance. And you can see in this frequently presented slide that quality of life deteriorates during transplant, but in the study it recovered quickly, certainly by the time that patients were established onto maintenance. This study included patients up to the age of 65, so we don't know how quality of life was affected in the older patient. So moving on now to the Maya clinical trial. This looked at Dara-Lendex versus Lendex in over 700 patients who were considered to be non-transplant eligible due to age or comorbidities, with the primary endpoint of progression-free survival. Again, these were fit patients with an ECOG performance status of 0 to 2 and good renal function with a creatinine clearance of greater than 30 mils per minute. 30% of these patients had advanced stage disease, and 15% of patients had high-risk FISH, as defined by 17p deletion, translocation 414, and 1416. But what I thought was quite interesting is that the median age of patients in the study was 73, and over half of patients were younger than the age of 75. Responses at 4 years were very impressive, particularly in the Dara-Lendex group, with stringent CR rate of 35% and MRD negativity of more than 30%. And again, this translated into a progression-free survival advantage. And this pooled analysis reported by San Miguel et al., they showed that progression-free survival was prolonged in patients with sustained MRD measured at 12 months, compared with those who didn't achieve sustained MRD negativity or who those remained MRD positive. And you can see there's an ongoing risk of progression in the MRD positive pool. Adverse events, again, neutropenia was increased in the daratumumab group. And quality of life, importantly, improved rapidly and was sustained in the Dara-VTD group. over the first 12 months of the study. So given that the older patient is underrepresented in contemporary clinical trials, we have to look at other sources of data to gain clues as to whether we can transplant these patients. So here I've listed 3 retrospective studies. You can see that they're all relatively recent studies performed in the last 10 years with relatively small numbers of patients, a mixed bag of conditioning. But the point here is that there's very low transplant-related mortality in this carefully selected group of patients. So looking now at a prospective multi-center study performed by Jarderet et al., they looked at upfront autologous stem cell transplant in newly diagnosed elderly patients, meeting my definition. There were more than 50 patients studied, and they received Velcade-based induction consolidation and went on to receive maintenance. And actually, a third of these patients, 60% of these patients went on to receive the higher dose of melphalan. Transplant-related mortality was 0% and very impressive progression-free and overall survival. My point here is that the comorbidity score is very low in these patients. So over 80% had a score of 2 or less. So these are very carefully selected. These patients are very fit going through the transplant procedure. And of course, we always think about reducing the dose of melphalan in the older patient. This wasn't randomized. Physician choices to the dose of melphalan received. And of course, melphalan 200 seemed to do better. So now I'd like to focus a little bit more on selection of patients for transplant. Frailty assessment is very important. So this is a study that is a prospective external validation of the IMWG frailty score. They looked at 131 patients in the older age category who were referred to the Centre for Transplant, and patients underwent transplant at the discretion of the treating physician. They then looked at the frailty assessment scores using IMWG and other criteria. So 65% of these patients went on to receive transplant, most of those patients were induced with VTD. And you can see that 40% of those patients are over the age of 70, and 17% of the patients were over the age of 70 and considered fit. So you can see here that patients who were considered to be frail, all of those went on the non-transplant pathway, and they had an inferior survival. You can see that survival is improved in those patients fit and unfit undergoing transplant. So I think this is quite interesting, looking at the age stratification. So that the younger cohort of patients, 65 to 69, do better than the older cohort. But within that category of patients aged over 70 and unfit, there wasn't much difference between those who underwent transplant compared to those who didn't. And the authors concluded that actually the IMWG frailty assessment is important at identifying those patients over the age of 70 considered unfit who wouldn't necessarily benefit from undergoing the transplant. You can see that this is different in the younger cohort of patients, 65 to 69, where despite being unfit, patients in the age category did benefit from transplant. So it's a multivariate analysis. Instead of age being a factor, ISS stage 3 and functional status were significant. So frailty assessment is absolutely key in selecting our patients in the older category for transplant, but frailty assessment is not straightforward. Frailty is dynamic. It can change. Patients can improve their fitness status after receiving 2 cycles of induction, whereas some patients experience treatment-related toxicity and become more frail. And you can see over time how patients move from one category to another. So when should we assess frailty? Should we assess frailty at diagnosis, or should we defer our frailty assessment for transplant purposes until patients have received at least a couple of cycles of treatment, or should we assess the frailty pre-transplant? And how should we assess it? We currently use the INWG criteria, but there are other frailty assessments undergoing investigation, including gait speed, grip strength, and a multitude of wearable technologies, and perhaps in the future these will include biomarkers. So changing tack ever so slightly now, I'm just going to chat a little bit about renal impairment. Of course, renal impairment is common at diagnosis, affecting 20 to 30% of patients. And those patients have a reduced overall survival compared to those with adequate renal function. So should we be transplanting these patients? Well, I'll start by presenting some nice data. I'm sorry, it's actually quite small. This is a retrospective analysis of patients transplanted at King's, and you can see that these included patients with a GFR of under 30 with and without dialysis. Melphalan was reduced to 140 in all but one of those patients, and in half of those patients with a GFR between 30 and 60. The conclusions here were that very few patients with advanced renal disease showed a worsening of their renal function through transplant, and no patient commenced dialysis as a consequence of the treatment. Progression-free and overall survival, very importantly, were similar across all EGFR groups. That was a retrospective study, so now looking at a prospective study. This looked at GFR, at patients undergoing transplant with a GFR of less than 40 mils per minute. They included 50 patients who were enrolled post-induction in recent years. Patients with AL amyloid weren't studied. 31% were on dialysis at diagnosis and 12% at the time of transplant. This was a younger cohort of patients with a median age of 56 years and relatively fit. All patients received Melphalan 140 conditioning. They all had a stem cell dose of at least 3 million cells and received prophylaxis with antibiotics and antivirals. And there was only one episode of transplant-related mortality. Renal responses occurred in 2/3, and a third of these patients became dialysis independent. So my conclusions are that four-drug induction is clearly affords deep remissions and long-term survival in younger patients, and Daralendex affords favourable outcomes in older patients. But there's a paucity of data about four-drug induction, transplant and maintenance in the elderly and in renal impairment. We can see that transplantation is feasible in fit, highly selected older patients, and is safe and effective in patients with renal impairment. The accurate assessment of fitness is key to the selection of older patients to undergo transplant. In the future, we can be optimistic that perhaps we'll have permissive treatment algorithms adapted to the fitness of the patient assessed after they've received initial induction cycles. And perhaps we won't be stuck with the binary situation of transplant or no transplant. Perhaps there'll be a middle ground, clinical trials, CAR T-cell therapy, and other immunotherapies. So, thank you.
Thanks so much, Kirsty, for a brilliant talk. Any questions? Matt, have you got... Just, sorry, 1 second, just for our online...
Just the original case that you presented, what did you choose to do in that situation?
I knew you would ask that question. Actually, we decided to start, because she was so fit, to start Dara-VTD before the colonoscopies. The patient had started, had consented for the Dara-VTD before she experienced that renal injury. And we have been discussing whether she should stay on that pathway. I personally feel that she's a highly fit patient, that she had some hypercalcemia partly related to hyperparathyroidism. hypothyroidism, which should recover quickly with induction treatment. But yes, I think there's still...
Kirsty, could you stand behind the microphone, please? Thank you.
Sorry.
Thank you.
Okay, thanks. We've got a question online. So would high-risk fish abnormalities push you towards transplant in these on-the-edge cases?
I think it does still influence our decision. As I said in my presentation, often we don't have all of the fish available when we're making a treatment decision, and it's something that comes out a little later on. According to those forest plots of responses, the responses are still better with the addition of daratumumab along the both transplant and non-transplant treatment pathways. But I think that if we knew a patient had high-risk fish, that would influence the decision.
Okay, any more questions in the room? Okay, great. Thank you very much, Kirsty, for solving that
I don't think I just solved it.
dilemma for us. Okay, so going to move on now to our first debate of the day. We've got 3 debates today, which we're hoping will result in us solving all of your unanswered questions in myeloma and all the controversies and uncertainties. We're going to start with a case, which I'll present, and then I'll introduce our 2 debaters. So this is a 69-year-old delivery driver presenting with a significant past medical history, cardiac disease. You can see the type 2 diabetes, which is diet controlled, and a pre-morbid performance status before this diagnosis of somewhere between 0 and 1. Presented with a 4-month history of constipation, a 3-month history of pain in the back and the arm, and came into the clinic to receive the diagnosis in a wheelchair because of the pain. But no focal neurology, struggling to sleep, but otherwise no other significant symptoms other than what we can see there. And was given the diagnosis of myeloma with an IgG lambda paraprotein of 23 grams per litre. You can see there high kappa lambda ratio with kappa sitting at 100, so not a huge light chain burden, but high corrected calcium, acute kidney injury with an EGFR of only 23 and baseline of 60. Anemic with an ISS of 3, as you can see there, and the bone marrow reported as showing sheets of plasma cells, approximately 80%. And on FISH, no IgH rearrangement, but the other analyses failed. Imaging showed a right paraspinal, locally invasive lesion, fairly destructive, as you can see there, and then extensive lytic lesions at a number of sites, especially in the sternum and in the vertebrae you can see there. So that's our case, and we've been given these options, so hopefully this is going to be your first opportunity to successfully vote. I don't know if we've got the voting page there yet. We've got a thumbs up. So you should be able to vote here and online as well. So here are your options. So you can give some initial resuscitation and then optimize the renal function and decide what you want to do. Or you can go straight in with induction therapy, thinking about proceeding to transplant, or think about a non-transplant eligible pathway, either with DRD, or you can see there the Velcade-based triplet, consider a clinical trial, or we've given you the get-out clause of other, which I don't think you should vote for, but you can if you want to, if you feel that something's not represented that you'd like to say. So I don't know, we'll give things another 5 or 10 seconds. I'm sure the technician will know how much more.
Yeah, give it a little while so people can log in here and online as well. Thank you.
Okay, so I'll give you a few more seconds to consider that. Okay, so let's see what people have decided. Okay, so almost half of you have decided to wait on that decision between transplant eligible or ineligible and see where the patient gets to once they've been optimized. perhaps we were a bit kind to give you that as an option, actually. We should have forced you down another option. As you can see there, a large minority then have gone down the transplant-eligible arm, and then just under 10% of people have gone for the DRD arm. So interesting, we'll see whether that changes. We're hopefully going to be able to vote on that afterwards. But I'm going to introduce now Kerry Bygrave and also Guy Pratt, who are going to solve this problem for us. They're going to debate whether or not we need frontline transplant in myeloma at all anymore, and hopefully will tell us what the latest evidence shows about that. Kerry's going to argue for. She's a consultant haematologist, clinical lead for myeloma at the University Hospital of Wales in Cardiff, chair of the UK Myeloma Society and a member of the UK MRA. And I'll introduce Guy before he comes up to defend himself. He's a consultant haematologist in Birmingham with a clinical and research interest in myeloma and Waldenstrom's, CLL, and plasma cell disorders such as amyloid, and he's professor of haematology at the University of Birmingham. And between them, they're going to battle out this decision. So thanks to you both.
Thank you, Andy and Sally, for inviting me to speak. So I'm going to put the case for autologous transplantation in myeloma and basically why patients still need it and deserve to benefit from it in the future. So the main thing I would like to start with is that transplantation has a proven track record. So as we've said, the UKMS has been around for 25 years this year. Transplantation in myeloma has actually been around even longer. So this was a publication in 1989 from Tim McElwain's group looking at some of the earliest data in high-dose melphalan autologous transplant. 1989, for those of you in the room, will remember is the year that the Berlin Wall came down and many people in Eastern Europe were able to enjoy more freedom than they'd had since the mid-1960s. Unfortunately, when we listen to Guy's side of the debate, instead of increasing people's freedom, we're going to be confining them to 5 years in the day unit, having subcutaneous daratumumab and continuous chemotherapy. So, high-dose melphalan transplant remains an essential part of our treatment algorithm. Essentially, what I'd like to argue is that it's well tolerated in the majority of people. Adequate patient selection is obviously required. With the increased use of the ambulatory route in the UK, it actually makes the procedure more patient-friendly. Until we have a cure in myeloma, and obviously we're all looking for a cure, patients want cures, that's what we're looking for, but it's not really sensible to discount effective drugs like melphalan until we've reached that point. And continuous chemotherapy, I would argue, doesn't actually cure people, it just confines them to the day unit and toxic medication forever and a day. But really, my entire argument could be summarized in this case. I have presented this lady at UKMS before, and essentially every year, touch wood, I'm allowed to present her again because she's still doing so well. So this is Mrs. B, who was diagnosed in 2014 when she was just 51 years old. She was ISS stage 3, IgG kappa myeloma. She had a paraprotein of 30 grams per litre, kappa light chains of over 3,000, mild renal impairment, mild anemia, and quite a lot of bone disease on MRI. So nobody can argue that she had MGUS and was transplanted. This lady had proper myeloma. Unfortunately, her FISH failed, so her revised ISS score will never be known. She went into myeloma 11 and had KCRD induction and an autograft in May 2015. Under the trial, she was randomized to no maintenance, and believe me, she was extremely anxious about this at the time. She mentioned it just about every single clinic visit for the first 3 or 4 years. However, I spoke to her last week. She remains in a stringent CR, almost 10 years post-diagnosis, and really, if we were oncologists and we had 10 years with no detectable disease, we would be saying that she's functionally cured. Now, if we stopped autografting people, people like her would not exist anymore. So now I'm just going to walk you through some of the studies that say the same thing in a slightly different way. So the first one is Forte, and this was an Italian study of frontline transplant-eligible myeloma, which hopefully most of you are familiar with. There were 3 arms in Forte. 2 of them included a transplant, and 1 of them was KRD for 18 cycles. And what the Kaplan-Meier curve shows you is that the winning arm was the transplant arm with KRD induction. Okay, KRD12 actually did better than KCD plus an autograft, but that's probably the impact of lenalidomide over cyclophosphamide. Then we have 2 trials from the French group and also the US group using VRD, chemotherapy or transplantation. These curves are quite difficult to follow because in this one the RVD is in red and in this one the RVD is in blue, so I apologise for that, but what it does show is that there's daylight on the PFS side between both those trials in favour of the transplant arm. So back to the IFM data, what is the benefit of transplant over continuous chemotherapy? And what I would argue is that by using high-dose melphalan, you can actually get a increased depth of response. And that was shown in the IFM data where if you look at complete response or VGPR, there was significantly improved numbers in the transplantation group compared to the group that got RVD alone. And what that looks like is that there was more than 10% higher CR or VGPR rate in the transplant group. And the same was also true for MRD negativity at 10 to the minus 5. And as we all know in myeloma, deeper response has been shown to improve progression-free and overall survival. And this is the overall survival from the IFM 2009 trial where you can see an improvement for patients who are MRD negative, and what we know is you are more likely to be MRD negative if you had a transplant. And so in myeloma we often talk about this iceberg, and right from the very beginning when I started seeing myeloma patients, it did strike me that if all we ever do is measure paraproteins and talk about CR, we're just ignoring a huge elephant in the room, which is actually what's going on in the patient at the bone marrow level or indeed at the extramedullary level, and that's where things like MRD can be useful to get a better visualization of the depth of response. This was an analysis that was published in Blood in 2018 talking about the depth of the myeloma iceberg, and basically they went back and again looked at IFM 2009 and showed that people who were MRD negative pre-maintenance had a 78% reduction in the risk of progression at 50 months, so more than 4 years after they were enrolled in the trial. And as we know from the previous slides, that group were more likely to have had an autograft rather than chemotherapy alone. This is some additional data that's been published to show the benefit of MRD negativity. This is Nicole Munchie's trial that was published in 2020, and basically patients who are MRD negative have an improvement in both progression-free and overall survival. What about the impact of transplantation in the era of modern agents? So the lady that I presented at the beginning had KCRD, which is a modern quadruplet induction regime, as has just been described. But when you look at this analysis of similar novel agent combinations, so we've got VRD, KRD, DARA, VTD, etc., what these graphs are showing you is that when you autograft the patient, in these studies there was an improvement in depth of response. And what we've said is that the advantage of melphalan is that it can do that for the patient following adequate induction. Quite simply, as Einstein said, the definition of insanity is doing the same thing over and over again and expecting different results. So if you have a patient who's had 4 to 6 cycles of induction chemotherapy and isn't in a CR or isn't MRD negative, if you just keep doing the same, can we really expect their depth of response to improve? Or do we need to shake things up and try something different like an autologous transplant? This also leads me on to the benefit of melphalan and high-dose melphalan in terms of improving depth of response, but also controlling the MAIA, that is the clonal heterogeneity in myeloma, which we're all faced with. So we know that when you give short-course chemotherapy, there can still be residual disease. There can also be clones that are resistant in different ways to different regimes. This is data from myeloma 11, similar to the data on the previous slide, showing an improvement in depth of response following the transplant. But actually what's happening at the patient level is that I always say to patients it's like a tube of Smarties, and all the colours are there at the beginning, and different drugs will control different colours to a greater or lesser degree. What we do when we give high-dose melphalan is that we can apply selective pressure and hopefully control the bulk and prevent more aggressive clones from expanding. The other point about giving continuous chemotherapy compared to having an autograft is that patients really don't benefit from being multi-drug refractory. And although it's great that we can now use regimes like DARA-VTD, and we can use DRD until progression in the UK, what that does mean is that when these people progress, they are going to be more heavily pre-treated, and that, as we know, can limit their overall survival in the future. So this study gets presented over and over again, but it's a real-world evidence study called Mammoth, where they looked at the experience of patients who were either triple, quad, or penta refractory, and their overall survival is very short. So we do have to be prepared that now the UK has the ability to use DRD and then perhaps a Velcade-based regime at second line. What are we going to do at third line? And so are we really in a situation where we need to take melphalan off the table when that can actually induce an improved depth of response and a prolonged first remission? There is also an economic argument. So we know that none of the drugs that we use to treat myeloma are cheap, although when you take all of them into consideration, actually high-dose melphalan comes out relatively inexpensive. So this is a comparison of the cost of high-dose melphalan with lenalidomide maintenance at 35,000 plus another 9,000 on top, with a median PFS of 5 years. DRD, on the other hand, can come in at around £100,000 per patient per year, with a median PFS of 5 years. So you're talking about £500,000, so that 5 years worth of treatment compared to 50,000 for the autograft and lenalidomide. Now, I'm not arguing that this is the way we should make all our therapeutic decisions. However, it is a difficult one to argue against. And again, as we've said, none of the drugs are cheap. None of them come for free, unfortunately. And melphalan down here, compared to some of the others that we might be able to give in the not too distant future, is extremely inexpensive. Kirsty's already presented this slide, so I'm not going to go over it too much, other than I am waiting for Guy to tell me that everyone feels terrible during an autograph, can't stop vomiting, and really hates every single second. I'm not going to pretend it's a walk in the park, and I do say that to all of our patients. This is going to be more arduous than anything you've had before. But actually what this data did show is that the dip was brief around the autograft and then recovers to the same level as when they were on chemotherapy only. Again, this has been touched on already, so if autografting is good, is there anything better than autografting? So this is a trial called Cartitude 6, which will open in our site and a few other sites in the UK in the not too distant future. And basically, it's taking the gold standard, which is an autograft, and seeing whether or not substituting that for CAR-T with cilta-cel can actually improve outcomes. So that's an EMN study, and I think it will be really exciting to see the output on that. There are other trials looking at frontline CAR-T, so Karma 9, I think, may also open in some sites, perhaps in the north of England later in the year. And again, that's looking at a different product called ida-cel as a way of kind of augmenting or consolidating following a standard melphalan autograft. So in summary, I would argue that a high-dose melphalan autologous transplant is still a crucial part of frontline myeloma treatment, and really there's 3 reasons for this. 1 is it's more effective than chemotherapy alone. 2 is that it's more cost effective, and those numbers really do stack up. And 3, that it reserves options for another day compared to making patients multi-drug refractory. So it's a bit like football, really. If you've got a really good player on the field, do you want to take him off and substitute him too early? I would argue not. Thank you very much for your attention, and thank you to Gordon for sharing some slides. Over to Guy.
Thank you, Andy and Sally, for inviting me today. I've given this talk before and lost before, so and you know when the next talk's on tandem transplant, you're really up against it. I would like to say that this is a really important debate and it should never go away, because I think transplant is quite a horrible procedure, and I can't believe that everyone's quality of life goes back to normal. Here are my disclosures. So my argument is that the survival benefit with a transplant is questionable, that we still need to be asking this question, and it shouldn't go away, really, because we have monoclonal antibodies now, daratumumab up front, and the last trials didn't have any monoclonal antibodies. I would argue that there are longer-term consequences of transplant which we tend to ignore, particularly on T cells and bone marrow. And then, of course, we've heard all the data on the Maya data, which looks fantastic. And also, we should probably be thinking more about genetics and MRD, frailty, when we're thinking about transplant more than ever before. So these are the last studies which Kerry's discussed. They're interesting studies in that one was done in America and one was done in France. The French got their act together and they did it much quicker, so there was quite a bit of delay with the American data coming out. They're identical apart from the length of maintenance, but this is really important when you look at the PFS results because they're very different. So the French just gave 12 months of LEN because they were scared then about secondary malignancies, but the Americans gave continuous LEN. Very similar studies, RVD, no antibodies, no DARA. This is the last data that we've got. And sure enough, there's a PFS benefit. I'm not going to argue against that. But if you look at this, there's a huge difference in the PFS in the American study compared to the French study. And that's because they're on LEN continuously. And a lot of the benefit, I think, from a transplant is probably due to continuous LEN. And we should remember that, really. But what about OS? No benefit, no obvious benefit in survival. So we're putting patients through this horrible procedure, and are we really giving them a survival benefit? Questionable. And this is a fault of the human race that we only look at positive trials. So this is when I was a registrar back in the 90s. We had all these transplant studies. They're all historical. But interesting, the ones that get quoted are the MRC7 and the IFM trials, which showed positive results. And then all these negative trials, of which are a lot, just get ignored. And I think this is a shame, really, that you have to have a positive result to get into a good journal. If you have a negative result, you'd get nowhere in life. And I think that's very wrong. And a lot of these trials were good trials, you know, HOVON, etc., Pathema. So I'd argue there's no survival benefit. And then we need to keep asking the question. So the deeper responses we have, the more MRD negativity we have after induction regimens, the longer patients are going to go before they relapse. And you have to question what's the additional value of a transplant if you've got hugely effective induction regimens. So we don't know whether the addition of DARA really influences the benefit of a transplant, doing an additional transplant or not. But of course, we've not just got DARA, we've got BiTEs and we've got CAR T cells. So yes, I am going to challenge Kerry and say, should we be having an arm that doesn't have a transplant in it? Should we be using novel therapies sensibly to try and avoid having to do a transplant? So there are trials of CAR T-cell therapy versus transplant, but there'll also be BiTE antibodies coming on earlier on in the disease, without doubt. You know, 60% response rates in the multiple relapse setting. So these treatments are hugely effective with very deep responses. And can we replace transplantation? So we have to keep asking the question. We can't just say it's the same old, same old. It isn't. So the obvious one is toxicity, and it's significant for a lot of patients. A lot of patients will not want to have a tandem transplant. We all know about the acute toxicity. It's fairly horrible. But what about the longer-term toxicity? Marrow recovery isn't always great. We know that there's a secondary MDS signal with high doses of melphalan. And we need to be mindful of the fact that patients are living for longer, and you see secondary cancers over time. So it may be if patients start living longer than 10 years, 15 years, we're going to see more secondary MDS. But what about the T cells? What happens to your T-cell repertoire when you have a stem cell transplant? It's not great. And these are the same T-cells that we're expecting to be used for CAR T-cell therapy or immunotherapy and by antibodies. And this just shows the acute toxicity, which we all know. This is the IFM study. So obviously in the transplant arm, you're getting much more mucositis, gut toxicity, etc. during the transplant period. So the next point has already been discussed in some detail by Kirsty. So if you look at myeloma 11 trial, so they have the intensive trial and the non-intensive arm, and this is the age range. There's a huge overlap, really from sort of the age of about 62 to the early 70s. So in other words, this patient age group is a grey zone. Some patients go down the transplant route, others don't. And this is really, I think this is probably the most important part of my talk. It's also alluding to what Kirsty says. We need to be thinking about this patient group in particular with better induction regimens that we've got now. Should we be really transplanting this group of patients where we're a bit uncertain when they've got some comorbidities, where we're a little bit uncertain about how they're going to get on? And we know that older patients don't do so well. They get excluded from a lot of the transplant trials, as Kirsty alluded to. So there's less data about older patients. But now we have fantastic induction regimens for the older patient. We have Dara-Lendex, and this is unprecedented. So Dara-Lendex, median PFS is 62 months. That's absolutely amazing. So there's something about a combination of an IMiD and an anti-CD38. So should you really be transplanting that patient in their early 70s where you're a bit unsure about their fitness, when you've got this regimen that's going to probably give them a very long treatment, a break from their disease coming back? And there's a survival benefit when you add in Dara as well. Sure, you can argue about day unit time. We do have an outreach service. I phone my patients. I send the LEN out. It can work. You know, this is the way I think we probably need to go. Our capacity is quite limited in our day unit with everything going on, so it really works for us. And the main toxicity that we're finding is neutropenia. We can manage that, be very proactive with GCSF, and you can manage it. But the other thing that we've always done is we've really historically ignored genetics, we've ignored MRD, and maybe we should be thinking more about using genetics and MRD to make our decisions around transplant as well, which we haven't really been doing probably enough. And MRD is very, very powerful prognostically, way better than complete remission or VGPR. And it's going to tell us something about the expected outcome for that patient. There's lots of meta-analysis showing this now. So if you compare MRD to CR, it's way better at predicting longer-term outcomes. So should we be looking, and Kerry alluded to this, and I agree with her, you know, should we be looking at responses and making decisions about transplant a bit later on, and also reassessing patients' fitness and frailty after some sort of induction, and maybe not making the decision from day one. And I think sequential MRD results as well are particularly powerful, and we saw this in Maya. So Maya, about a third of patients are getting MRD negative. That's unprecedented. And these patients who stay MRD negative have really great longer-term outcomes. So maybe we should be thinking about using MRD as a way of thinking about whether we should transplant people or not, particularly in that grey zone, whatever induction regimen we're using. And of course, MRD is a bone marrow, but you know, maybe eventually it'll get replaced by serum tests or some other way of measuring it. And we can't ignore genetics as well. So Matthew's going to talk about tandem transplants. We can't just lump all these patients the same. Genetics, I think, high-risk patients may be the ones where they do need a transplant. I don't know. But that should be part of the data that we're looking at when we make these decisions. So in short, I know I'm going to lose this debate, but it's a really important question. It never goes away. Don't think we've solved it. We haven't. The better induction regimens, the deeper MRD, the less likely it is that a transplant's going to be adding that much, except toxicity. Is it really doing a lot for our T cells? And we have great induction regimens for the non-intensive arm for patients now. And should we be thinking more cleverly about how we use a transplant as well? Thank you.
Okay, any questions in the room for either Kerry or Guy? Okay, not seeing any hands at the moment. I'm going to show you that vote again and see whether either of them have been able to swing the needle with regards to what you would do with the patient that was presented right at the beginning. I don't know if we've got that slide available. There's movement happening at the back. So I'm going to make the two results incomparable by telling you, please don't vote for option 1, whereby you don't do anything until you know how the patient is. So if we could push you into the middle 4 options, that would be great. And I'll do some bodgy statistics at the end and see whether anyone's won. So options 2 to 5 are your options for this patient, if you recall the case. Presenting with acute kidney injury, although you may not need to worry about that. Kirsty presented that data to us about transplant in patients with kidney disease. I think we've still got some votes coming in. Okay, waiting for a thumbs up, yeah. And the winner is, oh dear, yeah, I think we actually managed to push some people into other options, actually, it seems. So I was going to split up the 50% of people who voted for option 1 and add them 25% each to DVTD and DRD, but even with that measure, I think the transplant arm has won there. But Guy, you've managed to convince some people into DRD, and into a Velcade-based triplet as well. Some people have despaired and gone for a clinical trial. So overall, I think that's been a highly successful debate. And I think so important, I mean, this is, if you look around the meetings going on around the country, everybody's debating this issue. And the fact that you said at the beginning it's not going to go away. So such an interesting and important question. And I think the fact that so many people are debating it shows us that we don't really know what the right answer is in a lot of these cases. But we're going to have more opportunities to ask questions after the coffee break. We're going to have a talk on tandem transplant and then a panel discussion where you can ask all your burning questions. So we're a few minutes behind. We're going to come back at past rather than 25 past for those who are online, and we'll see you then.